Hello, I'm Ross Camich. I'm the director of the Thoracic Oncology Clinical Program at the University of Colorado. What does that mean? That means I'm a lung cancer doctor. And unfortunately, lung cancer is the single biggest cancer killer in the world. It kills more men and women than breast cancer, bowel cancer, prostate cancer, and pancreas cancer combined. Fortunately, in the last few years, we've been able to make some amazing breakthroughs, all by saying one size doesn't fit all. We've been able to find mutations or gene rearrangements that make one lung cancer different from another, and we can tailor the treatment to those abnormalities. But that's only going to take us so far, because if you draw it all out in a pie chart, there's still a huge unknown slice of the pie that's driving some lung cancers. I want to tell you about a project that we've developed to try and find out what's driving those cancers and to do something about it. Now, as you can see, I'm wearing a suit in a lab, and that's because this is not my lab. To make this project come alive, we needed a team of experts. This pie chart represents all of the different known molecular subtypes in the most common histological form of lung cancer called adenocarcinoma. Histology means simply what it looks like down the microscope, nothing more. And adenocarcinoma just means it looks like the cancer originated from glandular tissue in the lungs. As each slice of this pie was identified, it was a potential breakthrough in terms of being able to direct patients to specific targeted therapies aimed at their own tumor's personal Achilles heel. But note that there is still a large unknown slice of the pie. And those unknowns get even bigger when you start to look at all the other histological forms of lung cancer, like squamous cancer and large cell and small cell lung cancers. This is Dr. Lynn Heasley, PhD, a basic scientist on the team here who has been studying something called the fibroblast growth factor receptor 1 for several years now. By working on lung cancer cell lines growing in the lab, his group were able to identify that a significant proportion of many different histological forms of lung cancer, including adenocarcinoma, squamous cancer, and small cell lung cancer, seem to depend on FGFR1 in order to grow and thrive. They were then able to identify a series of different molecular signatures that can be used to predict if a cancer is going to be FGFR1 dependent, and, importantly, these signatures are very different from the mutations and gene rearrangements that have defined most of the other known slices of the lung cancer pie in recent years. In fact, these signatures, what we call wild-type overexpression signatures, would be missed by most of the molecular profiling studies that are currently being used in the clinic today. This is Dr. Fred Hirsch, MD, PhD, the translational scientist on our team. Because to make a difference in patients' lives, we had to turn Dr. Heasley's FGFR1 dependency signatures into what are called biomarkers, things that we can actually test patients' tumor samples for to pre-select them for treatment with an FGFR inhibitor. Now, because this is clinical research with experimental agents, stuff always happens. And of note, the drug we are using as an FGFR inhibitor recently identified a late onset risk of some blood or vascular side effects. However, as these seem to happen on average months after starting the drug, months after the time when we will have found out if someone's tumor is shrinking or not on the drug, after discussion with the Food and Drug Administration, we have updated our study so patients are informed of these risks, but plan to continue, given the very serious nature of the disease itself that we are treating. Now, you can fund a basic science project with a few tens of thousands of dollars. But when you take the basic science of Lynn Heasley and combine it with the translational science of Fred Hirsch, and we plan to screen actual patients' tumors to see if they have these biomarkers and treat them with a drug, we have a clinical trial. And then the cost goes up enormously. Because behind every physician, there is a mountain of paperwork. There is an army of clinical research coordinators, data managers, regulatory affairs coordinators to make sure that every T is crossed and every I is dotted. Now, we think those people are out there. We think there is a subgroup of people with lung cancer who are driven by FGFR, fibroblast growth factor receptor, and we can find them with these biomarkers and treat them with the drug. But they're going to be rare. And so instead of just looking in our backyard, we're going to put the word out on the internet. We're actually going to screen nationally. We're going to have patients contact us, and their tumor will travel to us at the University of Colorado. We will test it, and then if they're positive for one of these biomarkers, they will be invited to come here for treatment. That bigger picture view, that way of using the entire country, has never been done before. But just like crowdsourcing through the Consano website, somebody has to go first. Getting money to do this is problematic. The government funding of clinical research is very limited, and funding for lung cancer is even more limited. We have some money from the drug company, but they don't control the study, they're just priming the pump. We're using other smaller grants and philanthropy to make this trial a reality. If you would like to help us in that, we would be so grateful. We think together we can make a difference. Thank you. To see where, online, we hope patients will seek us out to get their tumour tested for these biomarkers and the chance to be treated with a drug targeted to these abnormalities, please check out our ponatinib clinical trial website at this address.